Attending today's webinar, Value-Based Care in PY26, Opportunity or Obstacle, presented by Michael Dudley of Arcadia and Colin Gibbons of Pearl Health. My name is Kaylee with Core Association Partners, and I will be moderating today's webinar. Please be aware that there will be a Q&A portion today at the end of the webinar. Your questions may be submitted in the question box on the top right corner of your screen, and it will be answered in the order received. Today's presentation slides will be emailed to all participants after the webinar's completion, and a recorded version of today's webinar will be available on your HLA members only resource page. Please allow 24 hours for that recording to be uploaded. Again, we would like to thank you for attending, and I will now turn things over to our speakers, Michael Dudley and Colin Gibbons.
Fantastic. Hello, everyone. Thanks again to the core team for allowing us to be able to speak with you today. We'll be talking a lot about value-based care. There'll be some moments where we provide some brutal truths on where we are with value-based care, but I think overall we'll keep the conversation positive and get you excited for next year. Briefly introduce some introductions. My name is Michael Dudley. I'm the Vice President of Enterprise Growth Solutions here at Arcadia. Little known fact, I'm actually on the board for the HLA Virginia. So I understand obviously the transition you guys have made for the last couple of years. I've been on the board, been a member though for the last 10 years and prior to making the name change. So it's good to be in front of you. As for my experience, I've been in healthcare technology for the last 10 years, specifically with the EHR side, helping physicians with workflows and be able to do documentation. I started getting excited about value-based care when I started learning about MIPS and MACRA and some of the quality reporting. And that's what led me to value-based care. I've been on the value-based care side for last 5 or 6 years now, and I do believe that's the right side of history, and I'm really passionate about the topic. I do a number of these presentations each year, and it's always interesting to hear where people are on their journey, but I do think we're moving towards value-based care inevitably. So I'll turn things over to my partner, Colin, and thanks again for having us.
Hey everyone, Colin Gibbons. I live up here in the Boston area. I'm the Director of Enterprise Partnerships at Pearl Health. Also been in the healthcare technology space for about 10 years, working in health systems, strategy consulting, medical devices, and now focused solely on value-based care. Excited to walk through the presentation today and look forward to answering any of your questions.
Good. So I think overall, I just want to get you excited about what we'll be covering over the next 58 minutes or so. We'll talk about the state of U.S. healthcare, where we are today, where we're headed, as well as also the status of value-based care, where have we come, where are we going? We'll address some obstacles of value-based care, what's holding people back from moving into value-based care, as well as also highlight some opportunities where value-based care can compensate for some lost revenue over the years between fee schedules and other things. And then I think most practically giving you some feedback as to how you can prepare for next year, some practical advice on what workflows, what things you can employ there at your practice, health system, community health center, whatever it might be, including a nice case study at the end to wrap things up. But again, I think we'll be covering a wide gambit, so we'll go ahead and get started.
Yeah, thanks, Dudley. And I think we can just start out talking about some high-level trends in the U.S. healthcare system. Don't think this type of data will be unfamiliar to anyone on the call. We spend far more per capita on healthcare costs than any of our peer countries, almost double the average of the group. And we do not receive the quality of care or the outcomes that you would think would go along with that. On the next slide, you can see that the US lags behind our peer group in life expectancy. The last 2 decades or so, we've lost almost all the progress that we've made due to obesity, heart failure, the opioid pandemic, lots of issues causing this sort of step back in life expectancy in the US. And we lag far behind our comparable countries. On the next slide, you can see some data around what that looks like today in terms of the increasing demand and how that's really accelerating past the supply or our ability to care for these patients. Today, we see about 120 million Americans with at least one chronic condition, meaning either diabetes, congestive heart failure, COPD, etc. and about 2/3 of Medicare beneficiaries have at least 2 chronic conditions. That number is going to continue to grow. Over the next 5 years or so, we're going to see about 1.5 million beneficiaries age into Medicare. And that will continue to put strain on the system as more folks get older and sicker, because we're going to see about 85 million Americans with 3 or more chronic diseases by 2030. The folks with chronic diseases disproportionately drive costs in the health system. And what's that going to look like in terms of our costs and our outcomes? We're going to see about 10% of GDP be spent on caring for these patients with chronic conditions. And about 80% of all inpatient admissions are for folks with chronic conditions. So you can see that this run of folks getting sicker and older is driving higher costs on the system. And on the next slide, we'll show you some data around the supply and how there's a PCP shortage in the United States. It's going to be significant and could be nearly 50K shortage by 2034. And that shortage is not the same everywhere in the country. If you are in a big city like Boston or New York or San Francisco, you likely have some access to a primary care provider. There may be wait lists to join more elite health systems, but you can get access, generally speaking. In more rural parts of the country, there are areas where there is no access to primary care. And that really drives a huge disproportionate amount of care to some of those patients in rural areas are sicker and they have less access. 1 in 4 PCPs plan to leave primary care within the next 3 years. And then fewer than half would recommend the career to someone who's just starting out in medicine. All trends that show us that the supply of folks that are able to care for the aging and more sick population is getting worse and worse. On the next slide, we'll walk through some additional data on why is there so much excitement behind value-based care and about what we're trying to do. I'll read a quote for you on the next slide about one of the top 50 value-based care thinkers, Dr. Porter. The way to transform healthcare is to realign competition with value for patients. Value in healthcare is the health outcome per dollar of cost expended. If all system participants have to compete on value, value will improve dramatically. Really what that means is we need to start thinking about, for every dollar we spend, how are we improving access and quality to care? So on the next slide, let's talk through about some of those initiatives that we've seen from Medicare to help this push towards value-based care. A lot of this started in 2010 with the passage of the Affordable Care Act. I'm not going to go through each of these programs in detail, but what I want you to take away from this is there have been a lot of programs that have started in the last 15 years or so focused on value-based care. The most popular are the MSSP program, the Medicare Shared Savings Program, which started in 2012. That's the largest value-based care program today. And another big program is the REACH program, Realizing Equity, Access, and Community Health. That program started about 3 or 4 years ago. Those two are big programs focused on value-based care, some that we'll talk about in more detail later. And you'll also see a few programs on here like Primary Care First and Making Care Primary that were recently ended by the Centers for Medicare and Medicaid Innovation. Dudley, anything that you want to add to the programs that we're seeing coming from CMMI and then some of the obstacles that we're seeing with some of this value-based care work?
Yeah, I think you hit on some of the major timeline points here. I think one of the things that everyone in healthcare is aware of is that healthcare data is relatively new compared to banking data or other industries. EHRs came out, in the early 2000s. Then through meaningful use, we were required to use an EHR system, or we lost some of our Medicare revenue. So I think that was kind of the introduction. And then really, as this has progressed, they're trying to do something with that data. Now that we're collecting it, how do we turn that into insights, or how do we use that data to be able to improve the lives of patients? So we saw MACRA come out. That was a big one, with MIPS really being an on-ramp. So if you're familiar with how MACRA is set up, you have two different sides. You have the MIPS side and then the APM side, or being a part of an ACO, such as the ones mentioned, MSSP, making care primary care first, and other models. So the goal, though, for MIPS was never to stay in MIPS. MIPS was really an on-ramp to get into value-based care, to join these ACOs like the ones mentioned. So I think that's just a call out, is that we went from no data to now what do we do with data, to now let's actually start to put this data on the line and start to be at risk with some of these patient lives. When it comes to obstacles, I think this is something to call out, something really important that I think has held groups back from moving into value-based care. And I'll list some of these, and we'll actually have a poll at the end, which one you might feel like impacts you the most or holding you back from fully going into value-based care. One of the analogies that people bring up when it comes to value-based care is the two canoes, right? So you have 1 foot in the fee-for-service canoe and 1 foot in the value-based care canoe, and you never really move either way. You just kind of do a little bit of fee-for-service and a little bit of value-based care, but never really fully commit to value-based care. And unfortunately, value-based care can't always be a pet project. If you want to be successful, like the use case we mentioned at the end of this presentation, it is important to be able to be all in and to be bought into this whole process. And we'll talk a little bit about that, as well as also population health here in a little bit. But I think one of the biggest obstacles is just the overwhelming reimbursement still in fee-for-service. And the reimbursement in value-based care is just not attractive enough. So, I think if the incentives were there, maybe that would be different. But this is a huge obstacle for a lot of groups we talk to. Second would be around physician documentation, and the administrative burden is just too much work. So for physicians, asking them to do 1 or 2 more clicks in the EHR system is the last thing that they want to be able to do. And so to be able to capture that risk adjustment or those HCC codes is really difficult to be able to change that behavior in physicians. Now, on the same end, on the back end for administrative work, being able to capture these care gaps, run those reports, get those in front of the hands of those physicians, or do the quality reporting on the back end, UDS reporting, other reports. It's just a lot of work. Sometimes, it takes 2 or 3 full-time employees just to be able to understand the quality reporting and how to be able to document that appropriately. And just overall, this is just a lot of work. And as you know, when it comes to healthcare, the administrative side and documentation side is relatively new. It's been around 20 years, but it's taken a lot to get to this point. And last thing they need is more. I think some of the things that are helping with ambient AI and things like that, but ultimately this burden is too much. Third, we'll talk about limited staffing. I think this also has to do with, and you guys probably know this, I'm sure many of you shaking your head, getting and keeping, retaining good staff is very difficult today, especially with this new generation entering the workforce. Just very difficult to be able to keep the existing care teams, as well as also scale them or start something new, such as value-based care, care coordination, a lot of the different programs that would lead to being successful in value-based care. It's literally everyone's wearing 17 hats, and it's difficult just to get done the daily task, let alone something new in addition. Huge obstacle for many groups. Another one would be data and interoperability challenges, to see the needs of patients and then be able to address them at the right time. So as you know, many of the EHRs, I've worked for an EHR before, so I know it's okay for me to be able to call this out, but a lot of these EHR systems, a lot of the groups that collect data, they keep it in their silos, whether it's payers or pharmaceutical data or whatever it might be. Keeping this information fluid and being able to communicate to each other, let alone weave it together like groups like Arcadia does. It's really, really difficult. And it's a big obstacle saying, hey, I'd love to be able to reach out to a patient once I learn that they left the hospital, but I don't have that data. I don't know what's happening outside of the 4 walls of my practice. So it's really hard to be able to engage with patients for transitional care management or other opportunities that lead to doing very well in value-based care. Next would be around technology and analytics to be able to measure and prove value. So oftentimes when it comes to deciding how you're going to use resources in your practice, your health system, your community health center, you have to be able to prove an ROI. So is this program working? And oftentimes it doesn't always look great at first. It's, hey, we're putting a lot of resources into this program. We're reaching out to patients. It's taking a lot of time. But are we seeing outcomes, the ones we want? And sometimes that takes years before that shows. let alone even if you do have that data. So having technology, be able to understand and run analytics as to which patients do I engage with, how do I be able to close these gaps, that takes a lot of investment. Next, we have regulatory and contracting complexity. It's constantly changing. So, just as it's difficult to keep up with the fee schedule, it's one of the reasons you're probably here today is just to hear what's going on in value-based care. What are some of the new programs that are out there, whether it's ACO REACH or other things going on. It's very difficult even for me to keep up with, and it's something that I do every day. So it is very complex. I do think that you're in the right place. You're doing the right thing just in coming here today and learning about these things, but it is a big obstacle for a lot of groups who just don't have the time to be able to keep up with everything going on in healthcare. And then last but not least is just patient behavior, right? There's a lot of reasons why patients don't follow through on directions. As we kind of the stat that's tossed around is that 40% of patients are taking a prescription the way that it was prescribed to them. And a lot of that has to do with things outside of the four clinical walls that you're serving today. Some of those rely on social determinants of health, equity barriers, and really just getting those patients to follow through. So I think when it comes to, hey, that'd be great if we could do value-based care. We'd love to be able to, set them up with this program or provide this for them. But I don't know if this is going to lead to actually changing any behavior in the patient. Very big obstacle and can hold people back. So core team, if we don't mind just popping up that poll, I'd love to just hear from the audience. What of these obstacles, which one do you feel like is the biggest for you, some of the most daunting for your group to be able to move into value-based care? I know they all probably play a role, but the one that's the most daunting. We'll probably give a minute or so for this. I appreciate everyone's comments here. Also, if you do have a question, feel free to pop that into our chat. We have a moderator looking at that. Happy to answer those questions as well. One thing I'll add on here that wasn't necessarily mentioned, but we'll talk about today is also specialists. How do specialists get involved? We mentioned so far PCPs. We also will incorporate a lot of specialties in the rest of our conversation. We're at 45 seconds. 5, 4, 3. All right, we can release the poll here. So which of the following value-based care obstacles is the most daunting for your group? At number 1, we have reimbursement not attractive enough. Completely understand that. We have 47%. We have documentation. Next, we have difficulty staffing a care team for additional tasks at 21%. Then we have regulatory complexity too hard to keep up with at 16%. And then documentation reporting too daunting, 11%. And then data interoperability and technology limitations, 5%. Fantastic. Thanks again for participating. I think that reveals a lot. And I think we'll talk a lot as we kind of shift the conversation to a little bit more about reimbursement, because that's what seems to be hit home for you. I think it'd be helpful for us to kind of really emphasize where the reimbursement might be. To the things to come.
Yeah, and to shift away from some of that doom and gloom, there's certainly opportunities for us to capitalize on things that are happening in value-based care. So it's a big opportunity for health systems and independent primary care practices to lower costs, improve health outcomes, and really place patients at the center of everything that's happening. CMS had a goal to have 100% of traditional Medicare beneficiaries in an accountable care organization by 2030. Accountable care organizations are essentially the entity that you can think of that administers a value-based care program and runs it. A lot of health systems have their own accountable care organization. Sometimes independent physicians associations come together, create their own accountable care organization, clinically integrated networks, or there's national accountable care organizations like Pearl that partner with health systems or independent groups to help them build up their ACO. About 55% of physicians across the country are aligned to an ACO today and are focused on delivering value-based care. And about 60% of payments across the country are in some way tied to quality and or value. Just saw a question come in. Do you see AI helping providers with their clinical notes? We are experimenting here. So I think the short answer to that is yes. Can give a personal anecdote, and Dudley, feel free to chime in. I was doing my annual wellness visit maybe 4 or 5 months ago, my provider took out a little phone and asked, hey, do you mind if my clinical AI scribe transcribes the notes for us? And he was talking to me about it. I asked him what he thought of it. He was very excited. He said he loves it. He can actually look at patients when he's talking to them rather than staring at the computer and just writing down everything they say. And I thought it was interesting when the notes got sent to me afterwards. We spent the first, 5 or 10 minutes talking about the Red Sox, talking about the Patriots, and all that stuff got taken out of the notes. The clinical notes cut out everything social we were talking about and was just focused on the direct patient care. So I thought that was very interesting, and I think that's a big opportunity. Dudley, anything you want to hit on for that question?
Yeah, we've had scribes for a long time, or dictation, or Dragon and other tools for a long period of time. But I do think that we've gotten to the point where AI has almost been commoditized at the ambient level to be able to capture these notes, be able to take these notes in a meaningful way. I think where we'll see so the answer is yes, I agree with you 100%, Colin. But then in addition to that, we're starting to see some nuance around capturing HCC codes and be able to really hit on things that are what were much more nuanced and would have to educate the physician on to be able to document. They could suspect these and be able to tee these up for the care team, for billers, for physicians to be able to kind of really go an extra mile. So I think that's when we think about PY26, when we think about what's coming, is that there are a lot of different tools out there. We've seen some fighting between, say, groups like Abridge and some of these startups that were in kind of the Epic incubator to now Epic starting to do it innovatively. And we're starting to see all across the board, whether you're in healthcare or not, having scribes, note takers, auditors sitting in meetings. They're very meaningful, and I think the main piece of it is that it allows a physician or clinician in general to be able to have that eye contact and have that one-to-one conversation with the patient, be able to identify much more than just documentation. So yes, it does alleviate some of the burden, but just like anything else that AI is impacting, it doesn't always relieve everything. I think what it does is just it shifts some of the burden from what was actually typing something out to now what do I do with all this information? How do I make this meaningful? How do I choose between all these suspecting HCC codes? And really, I think just like anything in AI, it doesn't remove jobs. What it does is just shifts jobs from one task to a different type of task. Hopefully that helps. But great question. We'll keep our eye on the questions as well.
Yeah, great question. Let's talk about some of the financial opportunities. I think that was the number one issue I saw come up in the poll. About half of PCPs, as we talked about, are in some type of value-based care agreement now. And 56% of those PCPs believe that they're compensated fairly in that value-based care agreement. They believe that the way that they're paid allows them to provide better holistic care to their patient panel. And they believe that the way they're paid is aligned with improving outcomes. So all those really hit to the point. PCPs believe that they're paid better, and the way that they're paid is more in line with patient care. And the next slide will really show that there's not really a negative opportunity here, especially for folks just entering the value-based care space, to make less money doing value-based care. CMS has really set these programs up that if you start in the Medicare Shared Savings Program, that you're still in a fee-for-service agreement. And when you start doing value-based care, your patient panel will be assigned a benchmark. That benchmark is the estimate of what CMS expects that patient to need per year in terms of dollars spent on care. If that benchmark is, say, $1,000, and at the end of the year, you only spend $900 treating that patient, there's a variance of $100 difference there, and CMS gives you a portion of that savings. If you ended up spending more money, CMS doesn't penalize you if you're in some of these, what I would call beginner tracks. MSSP has 6 different tracks, and there's several where it's sort of the training wheels to get you going, where there aren't any penalties. So you're still in a fee-for-service agreement in the Medicare Shared Savings Program. If you go into REACH, that moves you into a capitated model, which is a monthly payment that's fixed based on your benchmark, what CMS expects you to need for caring for your patients. But on top of that, if you do end up saving money and spending less than the benchmark assigned to your panel, then you get these additional savings that are described on the right. That difference between $900 and $1,000, you get a portion of that. And then you're ultimately working towards a way where you're providing better quality care to your patients and being paid for that rather than fee for service purely, which is the more care I provide, the more I get paid, which is the models we want to start to shift away from. And all these Medicare programs are showing there's value in shifting away from to bend the cost curve.
Hey, Colin, do you mind if I jump in just for 1 second?
Yeah.
One thing is, I think it's helpful to understand, I like to explain this, is how the shared savings is created, right? So whether it's Medicare Advantage or traditional Medicare or even a Medicaid program that you're at risk with, whoever that payer is sets a benchmark. And this is what they believe is going to cost for you to take care of this patient. And then there's the actual cost or total cost of care. And then the difference there is the shared savings. So maybe it's $1,000 per Medicare beneficiary per month, or maybe it's more. And your goal is to be able to spend on average $800, $900 per Medicare beneficiary per month over the course of your whole entire patient panel. Now that can be really tough. There's couple things to talk about just around shared savings while we're on the topic. One is to be able to improve the benchmark, or to make the benchmark that you're reimbursed for to go up. So for instance, if you're caring for a obese patient, you might receive $1,200 for that patient per month, versus if you're caring for a morbidly obese patient, you might be receiving $1,500 or $2,000 for that beneficiary per month. And so the goal is that you are capturing those HCC codes, so you are paid more, but you always want to be paid accurately. That's very important. And this is something that CMS and MA payers have been cracking down on. That's why you've seen some changes in the V24 to V28 going forward for some of those HCC captures. But I do think it's really important to understand that. And then I think where we focus a lot of our attention throughout the presentation is how do we actually lower the total cost of care, so that little beige looking rectangle there is increased. And the goal is that if you're providing more care for patients, hopefully in an outpatient setting and less in an inpatient setting, you're providing more holistic care and you're able to increase that rectangle. So just want to hit on that. Sometimes, we're talking to people that are new to value-based care. Really helpful to talk about benchmarks, total cost of care, and how shared savings is created.
Yeah, thanks for that, Dudley. And there's really a hierarchy of sophistication in these programs. There are some where you're taking on no risk, and there's some where you're taking on more risk. And the more risk you take on, the more reward there is for that. And that's sort of where you hit the top of this pyramid, where you start to talk about how are we managing our populations at a population level? How are we driving outcomes at a population level? And Dudley's going to hit on some of those population health management points in the next section.
Yeah, one last thing is just, when you think about capitation, this is, many of you are familiar with that term, but you're literally paid for this patient no matter what kind of care you provide. And so, if you're providing, if you're getting that $1,200, $1,500 or whatever it might be per Medicare beneficiary per month over the course of the whole year, that patient, you're, hopefully providing services throughout the year. But if they break their hip, you're responsible to pay for that surgery, or you're responsible to pay for that cost. And a couple of those incidents can unfortunately make the whole capitation triangle crumble. But ultimately, I think that's where people are going. There are a lot of models that we'll talk about that include that. But I just think it's important to understand, if that's kind of where we're going, what comes with that. And I specifically want to refer to risk. Obviously, I think some of the words could be better, and I don't really like the word value in value-based care. We feel like we're kind of getting something at a maybe a lower quality, or maybe even the word risk scares people away from value-based care. But these are important things to understand. And I think it's important to also embrace risk if you're interested in moving to value-based care. So let's talk a little bit about risk factors specifically. So, when we think about how we take care of patients and what that might look like in value-based care compared to the kind of care we're providing today, it's important to understand, where are the costs coming from? In this case, we kind of highlight chronic disease. This is where the majority of costs are coming from, are patients with multiple chronic conditions. So 90% of annual healthcare expenditures are for people with chronic conditions. 60% of US adults have at least one chronic disease, with 40% having multiple. Now, you're probably very familiar with some of these chronic diseases, but it's also important to understand how risk is impacting these. So for instance, some of these risk factors you see on the right side of the screen and how it impacts life expectancy. So for instance, if you were to get someone to quit smoking, you're able to add for women 2.39 years to their life, or for men 3.2. So the goal is, if you're controlling high blood pressure, if you're controlling excess body weight, if you're lowering high blood sugar, or increasing physical activity, you're able to add years to this life, hopefully improving the quality and quantity of those years. Now, when you think about this, I think it's important to also when you're thinking about risk, it's also important to understand what are high risk patients, what are moderate or rising risk patients, what are low risk patients. So if you saw some of those costs, here kind of goes down a little deeper. And again, this is one of the more morbid parts of our presentation, which is that 21% of healthcare spending is driven by that 1% of high needs, high cost patients. 49% of healthcare spending is driven by that top 5%. Really, do you have the capacities to be able to navigate these 21% or 49% of these patients? And so I think it's really important to understand where these costs are coming from before we start to think about risk and how that's tied there. We do have a question. What are the climate discussions of expanding value-based care beyond PCPs, and how are the commercial carriers viewing adopting expansion of capitation, excluding California state plans? So we do talk a lot more about specialists and how they're involved here. I think, even really when you think about this last slide, when you think about high blood pressure, when you think about some of the cardiovascular issues, or say nephrology or other specialists, they play a big role in this. We'll talk a little bit about the use case and more about specialists here in a little bit. But I think the question is more kind of around payers and how do they get involved. And I do think that it's really important, as you've been doing MIPS and MACRA, to understand what quality measures that are important to you, and performing well on those leading indicators. And if you come to your payer, you come to your clinic or integrated network, or you come to an ACO and say, hey, look what we're doing. Look at the revenue we're saving. How can we be able to take some of the shared savings that we're creating, and how do we get more involved? And I think that's the biggest piece here, is that we do believe that value-based care is an opportunity. And I think it's an opportunity for everybody. I think the PCP is oftentimes the quarterback, but I also think that they need people to hand the ball off to, and really be able to take care of that patient going forward. And they should be able to celebrate when they score that touchdown in this analogy. Great question. I think more will be disclosed in the next couple of slides, but I do think this is a good transition here for what Colin's going to talk about.
Yeah, we've talked about a lot of different programs, different types of risk, different types of benefits. Really, it's critical that if you're participating in value-based care, you find the right program for you. I think you can recall that timeline slide we showed towards the beginning of the presentation. There's a lot of different programs to pick from. And really what it boils down to is a few key things that you need to think about. Your historic savings. How has my panel performed in the past? And how would it have performed in some of those models? Some model-specific factors about, are there adjustments to be made from previous models? Has this model changed from when it was launched in 2022 to now? And does that benefit me or hurt me if I was to participate in that model? And then my practice and panel fit. Of my patient population, where does my group fit best? How much experience do my providers have in value-based care? And in which program can I be the most successful? And I'll spend, for the sake of time, maybe 45 seconds each on two of the biggest programs, the Medicare Shared Savings Program and the REACH program, on the next couple slides, just to hit on some high-level points. The Medicare Shared Savings Program is Medicare's longest-running value-based care program. It started in 2012, and there's significant savings that are generated through this program every year, into the several billions of dollars worth of savings distributed to the groups that are participating in this program. There's 6 different tracks. Track A is the track where most people typically start, and there's no risk in participating in that track. It's a fee-for-service track, and there's no downside, meaning if you end up spending higher than what CMS determines your benchmark will be, CMS won't penalize you while you're in MSSP A. the more you move down the risk track, the more you can make, but also the more risk your practice will be exposed to or your hospital will be exposed to if you aren't providing good quality care. In the REACH model, it's quite different from MSSP in that you shift away from a fee-for-service model into a capitated model, meaning you get a monthly fixed payment for your patient population based on that benchmark. That comes in every month. So there's no fee-for-service in this model at all. The administrative burden is significantly lower than MSSP. That's been one of the main challenges and pieces of feedback Medicare's heard from MSSP over the last many years. And there's also ways to align more patients to your ACO through voluntary alignment that allows providers to grow their panel throughout the course of the performance year so that it's not just patients aren't just aligned to their providers based on claims, but you can voluntarily align them in the middle of the year to ensure that they're aligned to your provider, you're responsible, and they're part of your ACO. So the last slide, I think I'll just hit on a couple other key questions and things to think about in value-based care before Dudley jumps into some more details in a case study for everyone. What are some things PCP should consider in the success of their value-based care program? Are my patients suited to the value-based care model rules? Does this value-based care program fit with my historical performance? Do the care patterns correspond to known drivers of success in this program? And then what level of risk is my practice or health system willing to take on to participate in this value-based care program? A few high-level factors to think about, and I'll pass it back to Dudley to sort of walk through some more details about these.
Good, I appreciate that. So we've talked so far about how healthcare costs are coming to a point where something has to happen. Whether we move to a single payer or lean in more on value-based care. There's a couple options, and I think we all would prefer the latter. So ultimately, now we learn about the mechanics of it. So what are risk factors? What are benchmarks? How do we earn revenue? What are the models? Now let's shift more towards what do we do, right? So like, how should I rethink how care is provided to patients in order to perform very well in value-based care? And I think a lot of that comes down to population health. Like everything, we like to be able to start at ground zero and talk about definitions, talk about what is population health. I think ultimately, the reason we're in healthcare is we're trying to be able to create health outcomes. These can simply be divided into length of life or quality of life, hopefully both. But I think, regardless, I think we're aiming towards improving both of these. And then there are a number of health factors that impact those health outcomes. And those are really divided into 4 different categories. And this is also how our health index across the nation, if you look at health counties, how these are graded. And we think about clinical care, this is what comes first to mind and the type of care that and health factor that we provide. This only counts for about 30% of all health factors. These would be access to care, quality of care, things that we're very, very familiar with. What we feel like might be out of our purview or out of our jurisdiction, but it is a health factor and it does impact how someone's length of life or quality of life is improved. These would be these other 3 categories, including health behaviors. These would be probably much more closer to clinical care. These would be tobacco use, diet and exercise, alcohol and drug use, sexual activity. These things, unfortunately, they're tough to tackle, right? So we could tell someone to not smoke anymore, but it's difficult for them to make that lifestyle change. But at the end of the day, it is going to improve the length of life or quality of life. How are we embracing that? What are we doing? What kind of programs do we have to be able to create those health outcomes that will later help us perform better in value-based care? Some others include social and economic factors, education, employment, income, community support. We're probably feeling like we're getting even a little farther away than what's within our day-to-day activities. But what can we do to be able to support employment, so that groups, or income, so that people can afford prescriptions, or what kind of community support can we provide so that patients are getting in front of a PCP or a specialist. And last but not least, physical environment, air and water quality, housing and transit. I think actually this last category, although it's one of the smallest, it's actually one of the more impactful when you think about what ACOs are doing. I know a number of ACOs are maybe calling all their COPD patients that are in the South and calling them and finding out if they've had an issue with their AC unit, or groups up in near where Colin's at up in Massachusetts, they've had an issue with their heater going out because they know that a patient might have an exacerbation of one of their chronic illnesses if something were to happen to their heating or cooling. What can we do to maybe replace that unit for $500, knowing that it'll save us $5,000 from them going to the hospital? Or what can we do to be able to provide transit programs so that people have transportation, can get to and from appointments? These are all things that, when it comes to value-based care, are really important, is to really take full ownership over as many of these health factors as possible. If you don't have the capabilities to do that, work with some of the community resources in your area to be able to try to tackle these together. All right, let's talk now more practically, more kind of that clinical care section. Like, what can we do to take advantage of this opportunity, really almost as a playbook? Some of the blocking and tackling of value-based care. What can I start to think about? And I think that's the other part about capitation is, like, if I were to get $1,200 per beneficiary per month, or maybe, taking into consideration averages and Medicaid, and maybe $1,000 per Medicare beneficiary per month, and I just got that coming in, what would I do differently? What type of care would I provide that would really be able to increase access, be able to improve quality reporting, and be able to lower the total cost of care? And that's what we'll get into some really, really good feedback, and then we'll actually talk about a group that's doing all of these things really, really well. One thing, when we think about how costs are coming into play, a lot of them are in the inpatient, when patients who are going to the hospital. So I think that one of the things we're trying to do in value-based care is shifting care from inpatient to everywhere. And I know there are a lot of independent practices, a lot of whether primary care practices or specialists here on the call. I know this is probably comes second nature to you, but I think there's a big shift here, and I think it's important for us to be able to volunteer and say, hey, I want to be a part of this shift. What can we do? And so I think there's a lot of health systems that even they're all thinking about heads in beds and how do we keep this revenue coming in, but oftentimes they're actually shifting the care to an outpatient setting, providing more care there throughout the year in hopes that when an issue comes up, they call that primary care practice, or they're leaning more on an outpatient side. So it's really an operational challenge. We need to shift from inpatient to outpatient, but we know how many of these hospitalizations are preventable. If we identify patients earlier, engage with them differently, and deliver care in a lower cost, higher touch settings, we can start to make this shift. Value-based care models create the space to do that. They let practices invest in chronic disease management, virtual visits, post-discharge follow-up, home-based care. We even see a lot of groups invest in mobile units, doing whatever they possibly can. If I know that money is coming in like a benchmark, what would I do differently to reach my patients where they're at? The best hospital admission is the one we prevent. And when we prevent it, we improve both the quality and the margin when you think about value-based care. Second, let's talk about risk stratification and trying to see patient trajectories. I know data and analytics was probably the lowest on everyone's obstacle list, but I do think it's important when you think about patient's trajectory. I think a lot of the costs that we see in healthcare are really around the high-risk patients. But those high-risk patients, like a stage 4 cancer patient, there's only so much you can do. You're really, in that case, just managing that episode, managing that patient's scenario, their life situation. But those patients came from, they were once rising risk patients. Something happened to get them to that point. Let's try to see if we could change their trajectory earlier on in the process. So I almost kind of think about this as like an airplane pilot. If you were to kind of change your direction, maybe 1 or 2 degrees, 5 hours later, you're in a different state than you were trying to be in. So it's almost understanding where these ticks are, understanding where these degrees. And again, I think when it comes to data, and that's the big part for you here at Arcadia, is that if I were to give you all the biomarkers my body could give you today, that's just one data point. But patient data is longitudinal, meaning that my data is going to change every day, every week, every month. And so it's really important to be able to understand where we are today as patients, or as you're looking at your patient panel, where are they today? And then which one starts to see that 1 degree, 2 degrees left or right in their healthcare based on maybe a scenario that happened to them with their family. Maybe they lost a loved one, or maybe they injured and broke their hip or knee, or something happened, something changed that trajectory. That's a great time to be able to interact with the patient. One of the things we do at Arcadia is we actually have like a ARC score, which identifies the most impactable patients, meaning that if a patient was just recently diagnosed with diabetes, or maybe have a new A1 score that was higher than that was in the past, that's a great time to get them involved in these care management programs and start to change these trajectories. So as we mentioned, the high-risk patients were once rising risk patients. They were patients starting to miss medications, showing new comorbidities, or visiting urgent care more often. Great time to interact with them. The challenge is, though, the signals are buried in a bunch of data. No single data source tells the story. You need to bring together clinical data, claims, and social determinants of health to spot that pattern. When you see rising patients early and intervene, you change that trajectory for their health and for the total cost of care. That's what the data enables, not just reacting to illness, but predicting and preventing it. I do see a question here. Looking at time, I think we can answer it here. I work in a cardiology practice, and we are being creative in how to get to those patients, how to bring them in. I appreciated your mention of 40% about them being compliant around prescription. We are providing resources in financial assistance and transportation, plus working with the Department of Health, who offers quit smoking programs. We work closely with the state's insurance administration due to this being an issue for our patients. We have issues with prior authorizations. That makes sense. We started tracking those issues from the staff is encountering the different issues that they're encountering. It's about getting the patient more engaged in their care, assuring the patients that their provider and staff care about them, and we are engaged in their care as well. We just get a round of applause for this question. I really appreciate it. I love hearing that. That's a cardiologist, a cardiology group that's really buying into value-based care, finding creative ways. I really love that question. More of a comment, but I really love that feedback. All those examples are what we're trying to hopefully get across to everyone here. Is it might be difficult, might be tough with staffing challenges, other obstacles that we've reviewed earlier, but it is doable. Here's one group, even a specialist who's doing it really well. Great job there. I appreciate that. Third, we'll talk about empowering the care team to act. Data alone can't change outcomes, people do. So I kind of talked about some technology and how do we identify these ticks or these changes in degrees of the trajectory. But at the end of the day, you have to actually reach out to those patients. You need good staff to do that. Value-based care only works when the entire care team can act on the insights. So nurses, pharmacists, care managers, social workers each have a critical role to play. When everyone works at the top of their license, we can scale personal care without burning out our clinicians. Imagine this. Your data identifies a rising risk patient, diabetic patient. Nurse's care manager calls to check in on that patient. The pharmacist reviews the meds. The health coach helps the diet. The physician focuses on the complex management. That is team-based care at work. The data points the way, and the team changes the outcome. So I had a great question earlier in the presentation around AI and how AI is impacting things. And I think a lot of people are focusing on AI around scribes and agentic documentation. But I think really when it comes to AI and how it impacts care, it's really being able to allow everyone to work at the top of their license. Meaning that if a nurse practitioner or a PA can do 70% of what a physician does, then just have them do that complex. Just have the physician handle the complex issues. Let that nurse practitioner, whatever it might be, handle that 70%. And then if an MA or someone else on the care team can provide, or maybe clinical pharmacist, whatever, can provide 70% of what that PA or nurse practitioner, then just let that nurse practitioner cover that other 30%. And so the goal is, if you're able to do that well, it starts with letting AI do the meaningless task, whether that's actually not meaningless, but the tasks that take up a lot of time, like documenting patient visits, or we see even a lot of groups do text-based automation, or be able to even have a care bot that is engaging with the patient. In fact, I know Best Buy, their home team is doing this right now, and I think their average call with some of their senior population is over 40 minutes, where the patient's just talking to an AI bot and just having a conversation with them. Now, we don't have that time, but an AI bot may. So I think that's one of the things is, when an issue is kind of hits a point where it needs that kind of top of life and needs to be escalated, that's really the importance of team-based care, is understanding when to raise your hand and get someone else higher involved, and then really be able to tackle as much as possible at the lower license level. Try to keep an eye on time. I think we're doing really well here. The last one I'll talk about is integrating the whole ecosystem. And this really, whether it's cardiologists or other specialists, we're seeing this a lot around episodes of care and really kind of the bundles. So if someone were to have, say, a surgery or something, then they have the orthopedic procedure done, the PT scheduled, some mental health, behavioral health things to handle, depression or things afterwards. Really important to kind of keep the entire team involved. And that's really what an ACO is trying to accomplish, right? So you have, a lot of different groups in ACOs. You sometimes have an OBGYN, you have a cardiologist, you have some PCPs. But the goal is that you're working together to manage that population. That's why I brought up population health. That's why it's at the top of that triangle is really, in order to do well in value-based care, you have to see the whole entire population, not just one patient to one patient, and try to manage that as best as possible as a big team. So we can't deliver value in isolation. Primary care might anchor the value-based care, but specialists, post-acute providers, and community resources all play essential roles in the patient journey. Integration means aligning incentives and sharing data so that whether a patient is in a surgery center, a skilled nursing facility, or receiving care at home, everyone has the same view of their needs and goals. When the ecosystem functions as a one connected network, patients experience seamless care and organizations capture the real savings that value-based care models promise. I really appreciated that. We last have a use case or a case study. This one's on Ochsner Health Network. Now you might be saying, Dudley, I'm not Ochsner. I'm a cardiologist in Arizona, or maybe I'm a nephrologist in Maryland. What does Ochsner have that I can take away? I think the big piece here is that Ochsner's leading the way in their community. They've been bringing in everyone into the picture. I think when we think about these health systems and their problems, the goal is really to think about their problems as your future problems, meaning that if you were to kind of follow their lead, one day you can be a part of what they're doing, but you could set it up with your local health system, your ACO, your clinical integrated network, and be a part of this network. Specifically for Ochsner, they have their own ACO. They also have a clinical integrated network with all of the practices, specialists in their area. So they are really truly managing the population. We described it earlier. Of course, they're a large group. They have 700,000 patients that they handle annually. I think it's really important to understand that they are a part of 20 total value-based care contracts, and they have 533,000 total lives at risk. Ochsner is one of our clients. We can't take credit for all that they do, but they also use our data and analytics to be able to accomplish what they do. And it's not easy. I give them the full credit on everything that they're accomplishing. When we think about their contracts, they have a lot. They have a commercial upside only. They have a Medicare shared savings enhanced track. They have Medicare Advantage full capitation. That's 43,000 lives there. Employee plan full risk, 40,000 patients there. Medicare Advantage two-sided risk, 25,000 patients there. Medicare Advantage upside only, commercial shared risk for 24,000, and then Medicaid upside only. So as you can see, these run the full gambit. We've gotten questions in the past of, how do I move into Medicaid value-based care risk? It's tough. It's very difficult. Those margins are much smaller, but it can be done. And Ochsner's doing it here as an example. So when we went through their change, they really kind of made a major shift in a couple of different ways. They were first focusing on chronic disease redesign. So thinking about the benchmark, how much am I getting for these patients? If I could redesign how I'm providing care, what would I do? And they really focused on some chronic diseases, which I thought was very, very helpful. I think what we kind of touched on what we discussed earlier. So CKD, CHF, diabetes, hypertension were the top four that they focused on. Then what they did is they standardized order sets and care pathways across all payers. Didn't matter if they were in Medicare Advantage, upside only, downside, whatever it was. They really just focused on let's just standardize everything. So if a patient comes in and has this issue, they have a very clear pathway as to where they're going and what kind of care is going to be scheduled for them. They also focused on fewer, more impactful interventions. So I think just like with everyone here on the call, there's only so much care or time that we can dedicate to patients. It's really important to understand prioritization and what kind of impactful interventions can we do. For them, it was more focused on that rising risk patients. So of course, the high risk patients, those stage 5 cancer patients, those situations need to be managed, but really it's engaging with these rising risk patients. They leave the hospital and so maybe they're willing to make a lifestyle change. Maybe they're willing to, stop smoking, or maybe they're just sick and tired of being sick and tired and just, they want to do something different to be able to make a lifestyle change. And that's where it takes time. That's where fewer, more impactful interventions can really make a difference. 70% of their redirected patients treated outside the ED. So they're improving experience, reducing costs in an outpatient setting. Very, very important. We've already touched on that a lot. The primary care physicians were no longer paid based on RVUs, but based on the performance of their patient panels. Huge here. If you will get what you incentivize. So if you don't have any incentivizations around improving the patient experience or be able to keep length of stay at a lower number, then you're not going to get those results. And last but not least, especially for the specialists on the call, specialists had a portion of their compensation based on value-based measures, such as clinical variability and unwarranted care. So getting these tests done 3 or 4 more times, or because it was done over here and not having that data, be able to reduce those as much as possible is very, very important. What did this look like? They had a number of different roles, and each one of those roles had core tasks. So here's kind of where we talk about, rising risk patients, rising or moderate risk patients, and then, where does the care team fit in? Not everything is a physician, not everything needs to be a nurse practitioner, but finding the right license level to provide that type of care. So as an example, for moderate risk patient support, you might be able to provide the patient education on preventive screenings, follow-up care, general health maintenance in our primary care practices in an outpatient setting. There might be some opportunities for psychological community support, really getting those licensed social workers involved. I do think that one of the best resources that I've seen groups do is actually work with their local church or religious organization and try to get someone who maybe was retired and say, hey, would you like to talk to Medicare patients every day and help them manage their chronic illness or help them their schedule? And a lot of times they'll volunteer to do these things. And so really kind of getting that community support is a big deal. But in this case, for licensed social workers, they might be willing to and able to assess these patient social support and risk factors impacting their adherence to the care plan, such as transportation barriers, other barriers we talked about around those health factors. You have high risk support, probably very familiar with that, creating this proactive care plan, providing patient self-management support, et cetera. Then you have the specialized support. So this is kind of where, when we think about PY26 and some of the things that are changing, this is a great opportunity to get MAs involved on more of a transition of care and just scheduling visits. We're getting a nurse or someone else involved so that they're making that care transition telephonically to ensure that patients are following in those directions, whether it's, the example we heard earlier around following through on prescriptions, et cetera. And then a big shift we're seeing is in-home primary care. That's a big deal. Being able to come and provide care where the patient is most willing and able to make those changes. So when we think about outcomes, we think about costs and how that's working out. We're starting to see a lot of shared savings. $44 million in CMS savings, $56 million in their clinical integrated network savings. They're seeing a lot of quality scores. So they ranked number 11 out of 476 ACOs in quality performance. They ranked number 3 in care coordination out of the same number of ACOs, and they ranked number 10 in timely access from the ACO perspective. So these are all great examples of how they use value-based care to be able to impact at the end of the day. Now, you can get access to these slides. You can feel free to read these, but for sake of time, I just kind of wanted to capitalize on this last piece, which is some critical capabilities for success in value-based care really kind of come to these 4 different pillars. Incentive structure, change how the clinicians are paid to see those desired results. Evaluate patient risk, identify high risk, rising risk patients to be able to determine your strategy. Have some tools for performance enablement that allow seamlessly within your tech stack and your workflows. And then be able to find a partner that might be willing to help you with downside risks so that you're performing well. So that concludes our presentation today. Thank you again for taking the time out of your day to learn about value-based care. If you have further questions, you can reach Colin or I at these emails. I'll turn things over to the core team.
Thank you so much to both Colin and Michael for answering our questions and comments during the presentation and for a wonderful webinar overall today. We're going to go ahead and wrap things up. So we just want to give, again, a big thank you to both Michael Dudley and Colin Gibbons for the presentation. Once again, the presentation slides will be emailed to all participants, and the recorded version can be found on our website. Please allow for 24 hours for that recording to be uploaded. If you have any additional questions, please reach out to the presenters directly. Thank you all for attending. Another big thank you to Michael and Colin, and we hope everybody has a great rest of their day.
Thank you so much. Thanks for joining.
Thanks, everyone.